Hello everyone. So I just made a quick little video here on the pelvic anatomy before we start taking a look at the physiology and pathology of the pelvis. So while we're going through this video, I just want you guys to make sure you're taking notes and you're fully understanding the basic anatomy before we start talking about what this anatomy does and then what happens when something goes wrong with the anatomy. So first we're going to take a look at the pelvis itself. So it's separated into two parts. We have our true pelvis and our false pelvis. Now the true pelvis is demarcated by what we call the pelvic brim here, and that's outlined by this red here. So anything caudally or inferior to that pelvic brim would be considered our true pelvis. Anteriorly, it's marked by the pubis symphysis here, and then posteriorly, it's marked by the sacrum. So we have our posterior border and our anterior border. Now, anterior and lateral, we're talking about this region here, we're going to have our hip bone and our obturator internus muscle. And then the posterior lateral wall will be demarcated by the piriformis and coccygeus muscles that come out here. Now our true pelvis contains all of our reproductive organs. That includes our uterus, our ovaries, our fallopian tubes. And then additionally, it's also going to house our bladder, our ureters, and bowel. So overall, that is the true pelvis. Now the false pelvis is going to be anything cranial or superior to there, leading all the way up to this iliac crest here. So again, demarcated by the start of the pelvic brim and then moving cranially until we reach that iliac crest. Now anterior, we have the iliac bones and again the sacrum, or I'm sorry, posteriorly we have iliac bones and the sacrum. And then anterior, we're going to have the abdominal wall. So if I'm looking at this picture here, posterior we have that spine and that sacrum, and then anterior we're going to have all of those pelvic muscles here. So it is going to sit posterior and kind of medially to all of those abdominal wall muscles. Now the false pelvis really doesn't contain any major organs. It really is just home of the bowel, and don't forget that appendix that sits within the bowel. So that is our true and false pelvis. All right, so let's go ahead and take a look at the muscles of the pelvis. So the big ones that I want to start with here are the levator ani muscles, and this is a group of muscles that really gives the form of the pelvic floor. So when we're doing our Kegels and we're trying to support our pelvic floor, these are the muscles that we are activating. And as we age, these muscles are going to start losing some strength to them, some tenacity. And this is where we end up with a prolapse or something like that. So let's go ahead and go over those, starting with this group here. So we have the puborectalis and the pubococcygeus and the iliococcygeus. And just to give reference here, this posterior aspect, that's going to be our backside. So we have our spine, we have our sacrum, and then this front part is going to be the anterior portion of the body with the pubis symphysis. These three dots here, so this first dot is the rectum, the second dot is the vaginal canal, and this third dot is the urethra. So knowing that, do you guys see this blue and this red line here? So both of these muscles are the puborectalis. The reason they're colored different here is because this blue section is actually going to be the prerectal puborectalis. And that means it's coming before the rectum. So we have a rectum here, and we have our prerectal pubralis, and then we have our puborectalis here, and they are both considered the puborectalis. One is just pre-rectum. Then we have our pubococcygeus, which is this green muscle here, and that just sits on either side, as well as the iliococcygeus. Those three muscle groups there form the pelvic floor, or the levator ani muscles. So moving on, we're going to now take a look at the iliopsoas, form the levator ani muscles. Okay, so now we are going to talk about the piriformis and the obturator internus muscles. So now that we've got this image pulled up a little bit bigger, we can talk about the psoas muscle. So the psoas muscle is this large muscle here, and it actually runs up all the way up the spine, and we can see this posterior to even the kidney, so it is a very large muscle. And there's actually two psoas muscles. So there's psoas major and psoas minor. So psoas minor kind of sits up here in this area, and it's much smaller. And then you have your psoas major muscle. And that psoas major muscle arises from the lumbar spine, meaning it comes from the lumbar spine and descends, coming down in the caudal position on the posterior aspect of the false pelvis. So remember, the false pelvis is from that iliac crest to the pelvic brim. So it is going to keep coming down. At that point, we have the iliacus muscle, which comes off the iliac crest. And at that pelvic brim is where the two fuse together to form the iliopsoas muscle. And this iliopsoas muscle is the landmark, the lateral landmark for the true pelvis. So when they come together, they're coming together right at that pelvic brim, and we now know that we are in the true pelvis. So that is our iliopsoas muscle. All right, so we are now going to talk about the piriformis and the obturator internus. These guys kind of go hand in hand. Yes, they're in that true pelvis lower fashion, but these guys start with inside the true pelvis, and they make their way out, and both of them kind of course toward the greater trochanter. So starting with the piriformis muscle. So the piriformis muscle kind of starts in this posterior aspect of the true pelvis, coming off of the sacrum, and is kind of a part of that pelvic floor that we talked about. And it courses through this greater sciatic notch right here and comes around to the back side of the pelvis. And as it comes out of this greater sciatic notch, it's going to course along this posterior aspect to connect into, and you can see it here, into that greater trochanter of the femur. Okay, and then we have our obturator internus. And the obturator internus, again, starts in that true pelvis and makes up the anterior lateral border of the true pelvis and surrounds the obturator foramen. So another hole that's kind of surrounding it. And then again goes through the sciatic foramen this time to the backside. So we have that sciatic notch, and then we have the sciatic foramen. And this one's going to come in through that sciatic foramen, and we are going to see it on the other side coming out here. So there's that sciatic foramen. This is our obturator internus muscle wrapping around into that greater trochanter along with that piriformis muscle. All right, pelvic ligaments. Now, there are some big players in the ligament game. Number one, and I'm going to show you guys a picture of this here in a minute, but I kind of just want you guys to understand where it's at before I show you pictures. So the broad ligament is just this massive wing-like fold, a peritoneum that drapes over the female reproductive organs, okay? And it drapes over the anterior portion. It only provides a very small amount of support to the uterus and really isn't even a true ligament because it doesn't support really any organ in any great capacity. But it does create our rectouterine and our vesicouterine pouches. So that anterior pouch and that posterior pouch, the reason we have those is because of this broad ligament. Now the cardinal ligament, which I will point out here in a minute again, it's a continuation of that broad ligament, and it's going to extend across the pelvic floor. Those muscle grouping, that levator ani muscles that we just talked about, it's going to extend across that pelvic floor to support the cervix. So cardinal cervix, all right? And then we have the ovarian ligament, and you guessed it, this is going to support the ovaries. So it's going to come out at the cornua where that fallopian tube comes out and go immediately to each ovary, okay? Next, we have the round ligament. Now, if you've ever been pregnant or heard somebody talking about having pelvic pain, usually this has a lot to do with that stretching of that round ligament because it does actually contract during labor and the days leading up to labor. Some women can experience that lower pelvic pain. But the round ligament's main job is really just to retain that flexation, that anterior flexation of the uterus, and make sure that we're not getting any retroflexion in it. So it comes from the lateral aspect of the uterine fundus to the pelvic walls, and we're going to see again a picture of that here in a minute. So then we have our suspensory ligament. Another name for this you might hear it be called is an indobulopelvic ligament. And this is what holds our ovaries in our pelvis. So it's going to hold those ovaries, it's going to be attached to the ovary and then go to the pelvic wall so that they are not just floating around like crazy, okay? And then finally, we have the uteral sacral. And this one is going to be easy to remember because it's going to go from that posterior aspect of the uterus all the way back to the sacrum and really create a big support for our cervix. If you guys are ever working on your Kegels, you are working on those levator ani muscles and really putting this uteral sacral ligament to work. So let's take a look at these ligaments all kind of put together, okay? So starting off, we have this broad ligament. So it kind of looks like a bat wing. If you think about it, you might hear somebody refer to it as the bat wing, and it is draping over the anterior portion of the ovary, that ovarian ligament, and the uterus. So it comes all the way across, and you can really see it draping here, okay? All the way over. All of this blue is going to be that broad ligament. And then we have our cardinal ligament. So like I said, our cardinal ligament is going to be supporting our cervix. So when we're looking for it, we're going to be looking near the cervix. Here's our cervix. There's our internal os. There's our external os. Where is the support here? Oh, here it is, not this lower. This one is actually going to be that uteral sacral ligament that's going to go posteriorly. But this one here is going to be our cardinal ligament, okay? And it kind of like houses those arteries and veins too. So if that's what you're seeing here coming out, these are not additional ligaments. These are those arteries and veins that are wrapping around that cardinal ligament. Then we have our ovarian ligament, kind of pointed it out here earlier when we were talking about that broad ligament. So this outpouching here is going to be in here too. So you can see there's our ovary, and here's it extending up to the cornua and to that medial aspect of the ovary. Now our round ligaments. When we're talking about our round ligament, it is going to be superior to that ovary, and it is going to, again, keep that flexation of the uterus. And how it does that, we can see it here really well. So this is our uterus with its flexation, and out of that lateral aspect wrapping around is our round ligaments. Suspensory ligament, that is going to be coming from the ovary here. And remember, it goes to the pelvic wall. So we're going to see it going in an outward manner. So we can see it here kind of going off into the pelvic wall. And again, here we have it coming from the ovary out to the pelvic wall. And then that wonderful uterosacral, which is the powerhouse of the cervix, we can see that coming. So this is going to be a transverse view. This is the posterior, this is the anterior. So we have our rectum, our cervix, and then we have our bladder. Okay, so that's what these three dots are. So rectum, cervix, bladder. And that uterosacral wraps around the cervix and goes all the way back to the sacrum, passing on its way the rectum. So you can see it here wrapping around and coming straight back here. Okay, so starts there and wraps back, really supporting the cervix. All right, vasculature. No exam is going to be complete if we don't talk about how these organs get fed. So for our pelvic vasculature, the really ones you need to know are going to be those internal iliac arteries and iliac veins. Now we know these from the aorta, right? The aorta comes down, it bifurcates, there's our common iliac, and then we have our external and our internal. This one, smaller one, is the internal. When we're doing legs, we follow that external. When we're looking at the pelvis, we're going to follow that internal. And this internal is going to give rise to our uterine artery, right? So that's going to break off right there, and it's going to come across here where it will give rise to our arcuate arteries. Now, our arcuate arteries, they really feed the myometrium of the uterus, and then it breaks off into our radial arteries. Those are smaller arteries coming into the endometrium here. Now these ones are going to be key that you guys remember this for your boards. So that spiral layer, oh good, we have one right here. So we have our straight coming in here, right? So we have our arcuate, then our radial. Our radial has our straight or basal arteries that are going to supply blood to the basal layer of the endometrium. Okay, and then going in, we have our spiral, and guess what? They're spiral, so it's perfect. These are what are going to respond to our hormones. So when you are having your monthly cycle, or a female is having her monthly cycle, these are the arteries that are responsible for that sloughing off of the endometrial canal. Okay, that's that spiral artery. So spiral responds to hormones. Now, we also have our fallopian tubes and our ovaries. And so we have to talk about how are they getting their blood flow. And so the main thing is, remember the branch of the aorta, we had these gonadal arteries that came off. Well, in the female pelvis, it is considered the ovarian artery, and it will come around and feed the ovary. But a really cool thing about the ovary is that it has a dual artery supply. So remember that lovely uterine artery? Well, it is also coming to feed the ovary. They are the powerhouse of reproduction, and so they require quite a bit of blood flow. So remember that it is a dual arterial system. So we've gotten blood to the uterus and the ovaries, but how are we getting blood out? Well, it's super easy. The same arteries that are going in are the same veins that are coming out. The only thing that we really need to remember is those ovarian veins, which is why I highlighted them here. So they're a little bit different. They are not going to empty directly into the IVC. In fact, the only one that empties into the IVC is the right one. The left ovarian vein is going to empty into the left renal vein. So it is going to go up, empty into that left renal vein, and then come into the IVC. So that's a super key fact that you guys will need to know for your boards. And then the other thing is that we really want to remember that suspensory ligament. So remember when we were talking about suspensory ligament, that it comes from the ovary to the pelvic wall, right? So within that suspensory ligament, you can see it coming off here, right? So there's our ovary. It's actually going behind here, that's why we can't see it so well. That's what's going to really hold our ovarian veins. And I talked about that a little bit when we were looking at those ligaments. So that is what you need to know about pelvic vascular. So we are going to move right along into other anatomy, which includes our pelvic spaces. So we learned back in abdomen that pelvic spaces are super important for infection, right? Whenever we have pelvic fluid, we're really kind of worrying about infection. Well, in the female pelvis, it's a little bit different. So once we get into physiology, we'll really talk about ovulation and how that cyst ruptures, and guess what? That cyst has fluid in it. And so every time one of those cysts ruptures, we end up with fluid in the pelvis. So we need to know when we are documenting on our ultrasound, where was that fluid seen? Was it seen anterior to the uterus or posterior to the uterus? And that's what we're going to talk about here. So the first one we're going to talk about is that rectouterine. So here's our uterus here, here's our bladder here, here's our rectum coming on up. So when we are talking about the rectouterine, we're talking about between the rectum and the uterus. Some other names that you guys will need to be familiar for your boards is posterior cul-de-sac. So guess what? Posterior, a cul-de-sac space posteriorly, and then the odd one, pouch of Douglas. So it's really the only one with a name back here. So Douglas, kind of being inappropriate here, but Douglas Dookie, right? So we have our rectum that may have some fecal matter in it. That'd be a good way to remember that. Okay, so it's anterior to the rectum, posterior to the uterus, and this is the most common place for fluid to collect because it is the most dependent place. Okay, when we have gravity working for us, it's going to go posteriorly. Then we have our space of Reitz. This is going to be that small little space anterior to the bladder, but posterior to the pubis symphysis. So when we're looking, here's our pubis symphysis here, here's our bladder, there is that space of Reitz right here. Another name for it, retropubic. There you go, behind the pubic, or prevesical, pre-bladder. So retropubic, pre-bladder, or space of Reitz. And then, of course, we have our vesicouterine pouch, which is wonderfully named because we have vesico, meaning bladder, and uterine, which means uterus. So between the bladder and the uterus, we will have that vesicouterine pouch, also called the anterior cul-de-sac, which makes it super easy to remember. And we are going to be checking all of these spaces as we are scanning to make sure that there is no fluid in them. So let's go more into each one of these anatomies here. I really want to focus on each one kind of independently, taking a look at each one's measurements, how they look sonographically, and really their overall structure, and possibly a couple of congenital anomalies that we may see. So starting with the uterus. So it is a hollow, pear-shaped organ that sits in the true pelvis. And as we learned earlier when we were talking about ligaments, it is supported by the cardinal ligament, uterosacral ligament, and that pelvic floor, those levator ani muscles. When we are really young, before 7 or 8, we have not reached menarche yet. We are what is considered pre-menarcheal, meaning pre-period. We have not had our first period. Menarche meaning the start of the first period. And when we are in that stage, our uterus and our cervix are much smaller. In fact, our cervix is 2 times the size of our uterus. So if you are scanning a child, prior to menarche, you are going to notice that their cervix is much longer or much larger than their uterus. But once we get into menarche, once we have that first ovulation, that first period, our uterus is going to grow. And it is going to continue growing into our 20s, okay? It's going to just keep getting bigger. So notice that when you're scanning, and it kind of sticks to this rule of 1-to-2 ratio, meaning that our cervix is half the size of our uterus. All right, and then once we age and we're no longer having our periods because we're no longer ovulating, and we go into menopause, once we get past that postmenopausal age in our 50s or so, it is going to start to shrink. Something that is, you never heard, you use it or you lose it. Well, we're not using our uterus anymore, and so it is going to shrink down to be roughly the size of our cervix. So now we are in a 1-to-1 ratio. The other important thing to know about the uterus and the ovaries and everything is that organogenesis, the start of organ formation, they are going to be formed by what is called the Mullerian ducts. This is going to be a key term for your boards. If you see Mullerian ducts, remember that it is the uterus we're talking about. The other one that you may see related to the uterus, which we're going to talk about this later, but I'm just going to pop it in there, is the kidneys. They kind of form at the same time. So if there's an issue with the uterus, there may also be an issue with the kidneys. So keep that in mind. So back to the uterus here. So we have 3 main tissue layers for the uterus. We have the perimetrium, meaning outside of the metrium, and that's going to be this outer serosal external surface here. Then we have our myometrium, meaning muscle of the metrium, right? That big old meat section, the thickest layer that contains all of those uterine arteries, and coming in deeper, we then get our endometrium. So this is actually a hollow space, or a crevice, you can say. And again, this is the area where we have changes in the thickness and the layers based on where we are in our hormone schedule. So keep those in mind. We're going to talk a little bit about the uterine segments now. So the uterus is divided really truly into 6 different segments. I know when you guys were scanning, you kind of talked about body, fundus, cervix, but for the boards, there are more than just that you need to know. So non-scanning, we have our fundus. This lovely fundus, it is the most superior or cranial portion, and it is going to be superior to where these fallopian tubes insert. So keep that in mind, superior to the insertion of the fallopian tubes. And then coming down, this section here and this section here are going to be our cornua. And if you think about this as like a deer's head or a ram's head, right? We have the head here, and then we have these horns that come out. These are the cornua or hornua, right? So cornua coming out, and this is where those fallopian tubes are making their way into the uterus. And then we have the body, this big old portion here. It is the largest portion of the uterus. That's really all you need to know. It doesn't have any fancy things about it. Just it's the largest portion of the uterus. Moving caudally or inferiorly, we have the isthmus. Now you may hear the isthmus, this lower uterine segment, called the lower uterine segment, especially in pregnancy, because unless the patient is pregnant, we're really not seeing this isthmus part. And once they're pregnant, we then term it the lower uterine segment. Then we get into our cervix. This one's nice and open, but we have our internal os and our external os. So make sure that you understand that the cervix, it has the internal os, which faces into the endometrium, and you have the external os, which is continuous with the vagina. And then finally, we have the endometrial canal. So as we've seen scanning now, the uterus has tons of different positions that it can kind of rest in. So we can have multiple varying different positions, and that is mainly because of that wonderful broad ligament and how stretchy it is, right? So before I go into the specific things, I want to point out what flexation and reversion are, which is going to help you when you're talking about the relationship of the anatomy and how it's like. So flexation is going to be between the body and the internal os of the cervix. So that is wholly related to the cervix and the body of the uterus. Now, reversion is going to be between the cervix and the vagina. And so if you're really talking about flexation or version, look at what it ends with. Does it end in version or does it end in flexion? And we're going to see here flexion, version, flexion, 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 version as we go through them. So anti-flexion, meaning forward between the body and the internal os, right? So the body bends significantly till it rests on the cervix. Perfect. So we don't have, oh, we do have one. Good. Okay. So here's our anti-flexion right here, kind of bending forward. It would almost be even more here because the cervix and the fundus are not touching. So this would be even more of a drastic bending forward. Then we have our anti-version. So this is where the cervix and the vaginal canal kind of make a 90 degrees. So if I was to put an L in here, that cervix and that vaginal canal would be sitting at almost a 90-degree angle, right? It looks like a perfect L if you kind of turn your head. Then we have detroflexion. Now this isn't really a forward or a backward. It actually means to the side. So dexo actually means to the right side. So this is where the uterus body is going to be kind of slightly to the right of the cervix, because we are talking about flexion, so we are talking about the body and the cervix, right? And then we have levo, left levo. That's going to be where the uterus is slightly displaced to the left of the cervix. Then we have retroflexion, so this is going to be behind, retro meaning behind, and flexion meaning between the body and the cervix. So we've got here, we've got our cervix and we've got our body, it is going behind. And then we have retroversion, where it would be more drastic than this, but they would be at a 90-degree angle between the vaginal canal and the cervix. All right, moving away from those normal positions, we're going to talk a little bit more about normal variants now. So these are an issue with how those Müllerian ducts formed at organgenesis, and each one presents a little bit differently. So there's quite a bit here. So we're going to try and step through these and kind of point out the differences, and we're going to go through these pictures down here at the bottom so you can really kind of see how they all look. So remember, this is going to be related to what happened with those Müllerian ducts during organgenesis. So first is, there is no uterus. This is agenesis of the uterus. This means that those Müllerian ducts never formed a uterus. Then we have arcuate. And the arcuate is really that cute little heart shape when we are in transverse or sagittal, when we're scanning and we get that cute little heart shape appearance. There is just a very slight separation in the superior aspect of the endometrium. Guys, I'm right here on this one, if you're wondering. So we don't actually have a separation. It's just kind of like a little dip. It should kind of bump up here, but instead it dips down. And so that's going to be our arcuate. Then we have our bicornuate. And our bicornuate can kind of be a variation. So here we have a bicornuate here. Here we have a bicornuate here. And the big difference is whether the bicornuate is just in the upper portion and not including the cervix, or if it now includes the cervix. So there will be myometrium separated, right, between the two of them. So we have endometrium here, followed by myometrium. There's a significant dip in the fundus, and then we have myometrium and endometrium. Now this one does not include the cervix. Notice there's only one cervix here. So this would just be a unicalis, meaning only that upper portion. Now the bicornuous bicalis is now going to include that cervix. Okay, so endometrium is separated with myometrium all the way down. We have two cervical canals. And as you're sweeping through, you're going to notice that the myometrium is continuous, but your endometrium will disappear, and then it'll come back again. Same thing with that cervix. Then we have our didelphys, and this is really, again, there is a variation, right? So we could have only one vagina. This one actually has two, so we have a septation between the vaginal canal as well, but this may not be there. The big thing that I want to point out, difference between this one and this one, right? So in the bicalis bicornuous uterus, the endometrium and the cervix are separated. Well, they're also separated here. So how do we tell the difference between the bicornuous and the didelphys? The big thing is this space here. So the myometrium will end, and it'll look like they have two uteruses completely. So it'll look like you left one uterus and went into a second uterus. Remember this one, I said that myometrium continues. So you can tell you're still in it. It just looks like, may have like a mass-like appearance, but you can tell that it's the same uterus. With the didelphys, it will look like two uteruses as you are scanning, and you may even see two vaginal canals. So that's the difference between your bicornuous bicalis and your didelphys. Now our septated uterus is going to look very much like our bicornuous unicalis. Again, the variation happens up here in the fundus. So we have a nice dip here with the bicornuous unicalis, but in the septated uterus, we just have a septation there. The fundus looks normal. We have a normal fundus, but then we have a dip into our endometrium. Our septus is going to be kind of the same thing. We may have a slight change in our fundal contour. Not really. It's just not going to be as deep as our septated. So our subseptus, meaning not fully septated, doesn't come all the way down. This one came all the way down, right? And in the same regard, their fundus looks a whole lot alike. Last but not least, we kind of already talked about arcuate, right? So last but not least, we're going to look at this unicornate. So what happened here was, instead of having two cornua, right, because remember we talked about we have our fundus up here and then we have the cornua of the uterus coming out here. Well, this one doesn't have a second cornua. It only has one cornua, and it can be both sides. It doesn't necessarily have to be, because this one is kind of pointing to the left. It can be a unicalis on the right. So this can be an inverted image if necessary, right? If that's the way that those Mullerian ducts formed. The thing that we may notice, though, when we are scanning a unicornuate, we have like this residual lobe here. And so it'll look almost like a mass coming off of it. And so noticing that there's no cornua on this side is going to be your key in determining whether it's a unicornuate left or a unicornuate right. Okay, so those are our congenital anomalies of the uterus. Small variations between the endometrium, the fundus, and the number of cornua that we have. Now, with all of these, except for the normal uterus, as soon as we have an issue with the formation of the uterus, we have increased our risk for pregnancy loss or infertility. So women who have this really septated bicornuous or didelphus, these guys can actually get pregnant in both uteri, right? So we can have a baby in this one because we have a second vagina here, and we can have a baby in here. So they can actually get pregnant with twins that aren't twins at all. They can have two different dads or whatever, you know. But these guys here, they're really going to struggle with infertility or increased pregnancy loss, especially in the second trimester with these guys here. So when we have that full septated, divided endometrium, second term pregnancy loss increases. Other than that, these are all asymptomatic. You're not going to have heavier periods or pain or anything like that. Generally, they're found incidentally or because of infertility and pregnancy loss. They were getting ultrasounds to see if something more was going on. So there are congenital anomalies. Now let's look at uterus and vagina and endometrium on ultrasound. So the uterus, depending on whether you are looking, so this is a transvaginal approach here, and this is a transabdominal. We know that because we have that deep curve here, and we just have a shallow curve here. So it is always going to be posterior to the bladder. We have our bladder there, and we have our bladder there, and it's always going to be anterior to the rectum. So we have our rectum here, and we have some rectal bowel coming here. So anterior to the rectum, posterior to the bladder. The uterus is a homogeneous low-level structure, and within it we have a hyperechoic endometrium, and we can see that slightly hyperechoic endometrium. Now the endometrium itself is going to have two shades in it as well. That outer basal layer is going to be slightly hypoechoic, and we can kind of see that hypoechoic line going around it. And then the internal functional layer that gets slothed off and responds to our hormones is going to be hyperechoic in comparison. Now, no matter once we hit menarche, once we have that first period, it's going to change every month. So we may have someone who has a centimeter long endometrium, or we might have someone who's in the beginning of their period or at the end of their period, and they're going to have a thinner endometrium. We're going to talk about that once we get into physiology. But no matter what age or grouping that we are in, whether we are pre-menarche, menarche, or post-menarche, we will never have a endometrium greater than 1.5 1.4 centimeters feather, okay? And that is an AP diameter. And you can see here, remember our screen orientation, superior, inferior, anterior, posterior, anterior, posterior, superior, inferior, right? And so it's going to be an AP diameter going from here to here across the endometrium, like that. And then when we are in transvaginal here, we are not going to see the vaginal canal, remember, because our camera is coming in here and it is in the vaginal canal. So we are not going to see vaginal canal when we are transvaginal, but when we are transabdominal, we will. So we have this low level echogenic line with a central echogenic linear line in the center of it. So we have, here's our vaginal canal coming all the way here, and there's that bright line. And here are our fornices coming up here, and then our cervix, and then into the uterus we go. So there's our vaginal canal there. And again, we have our cervix here, there's our fornice, and there's our vaginal canal with that bright hyperechoic line inside. Alrighty, we are talking about the ovaries and their anatomy and their function. Not so much, just a very slight touch on it. Once we get into physiology, we'll really get into depth about what the ovary is doing as it's just drifting along in our pelvis. But we are going to talk about some of the sonographic implications of the ovary. So just to get started, the ovaries are paired elliptical shaped organs that hang out on either side of the uterus. And their main job is to produce ovum and to let the uterus know that it is pregnant or not pregnant, so it can respond by sloughing off that endometrial layer and getting ready for a pregnancy. So main job, transport or to produce a mature ovum to make sure you get pregnant. So with that being said, as we are born, all females will have all of the ovum that they are ever going to produce inside of them. Once they reach menarche, the age of their period, they're going to start ovulating. And as they keep ovulating and ovulating, all of these eggs that they had stored are going to mature and be gone. And then they will go into menopause. So menopause means that we have used up all of these ovum, there's nothing else being produced, and then once we are in menopause, the ovary has no job to do because there's no babies, there's no reason to tell the uterus that it's pregnant or not, and so it will stop producing those hormones and it will decrease in size. So if you are scanning an 85-year-old female looking for her ovaries, good luck. You're probably not going to see it, especially if she went through menopause in her 50s. So just keeping that in mind as you're scanning, if you don't use it, you lose it. And that is what happens to our ovaries as we age. The ovary is truly the only organ in the abdominal pelvic cavity that does not have a peritoneum around it. So it is kind of open and free floating, right? There is that dual blood supply that we talked about, right? We have the ovarian artery and we have the uterine artery. So that ovarian artery comes off the aorta as a gonadal artery, goes into that ovary and feeds it. And then off of that internal iliac, we get the uterine artery that feeds both the uterus and that ovary. So keeping that dual blood supply in mind, we have two arteries feeding one organ. Thinking about its structural layout, the ovary looks a whole lot like a kidney. So let's just take a look here. Here's our ovary, and if we didn't have all of these cute little ovum, all these cute little ovum there, it would look a whole lot like a kidney, right? We have our hilum that comes in, and this would be like our collecting system, right? That collecting system, and then we have the cortex, the outer cortex, and it's very true for the ovary. So this outer cortex contains all of our follicles, and it is covered by the tunica albuginea. It sounds a whole lot familiar because it is. It is the same covering over the testicle. And so as females or males, we all have a tunica albuginea covering that reproductive organ for gamete growth. So for the males, it is sperm. Those are their gametes. For the females, our gametes are ovum. And so the tunica albuginea will cover that cortex of the ovary. Now the inner section, that red here, is going to be our medulla. So this has all of our blood supply, right? Those two arteries feeding it and the vein taking blood away, and connective tissue. So it is kind of the powerhouse, right? It's going to make sure that we get enough blood to grow nice, big, juicy, healthy ovum. The other thing that we want to keep in mind with the ovary is, as I mentioned, they're not covered by peritoneum. So the superior, lateral, posterior borders of the ovary are not covered. The only part that is kind of covered is that, sorry about that, my computer seemed to disconnect. So what I was saying is that medial, lateral, and posterior borders are not covered, but that anterior portion is covered by that broad ligament. And so the rest of the ovary is kind of free to float. And so we're not always going to see it in the exact same place, but there is a range of where we do see it. And generally, that range is on the superior aspect by the cornua of the uterus, on the lateral aspects. So we're going to look out to the lateral, up by that cornua where the fallopian tubes are. But keep in mind, it can range anywhere from the pubis symphysis up to above the fundus of the uterus and out to the iliac crest of the adnexa. So keep that in mind when you're asked where they are or what their location may be. It is variable. Generally, though, they're found up by that cornua of the uterus. Some just a couple congenital anomalies. There's not much to go over here, but we talk about these being an elliptical shaped organ, but that's not always the case. We might end up with one that has more of an L shape to it, and that's totally normal. There's nothing wrong there. Just make sure that you're seeing those follicles inside of it instead of a possible exophytic mass or something hanging off of the ovary. Okay, so when you see an odd shape, let's make sure that it is truly an L-shaped ovary versus a mass hanging off the ovary. The other thing is agenesis of the ovary. Now we can have agenesis, complete agenesis, meaning that neither ovary formed, and that means that that individual is sterile. They cannot produce ovum because they do not have an ovary. The other thing is we might have a unilateral ovary, which is super rare, which is why I highlight it here, but they may be missing either just the left or just the right ovary. So keeping that in mind if you're truly having trouble seeing the ovary. Sonographically, we are going to be looking for medium low-level echoes with that ovoid shape with our follicles present on it. It kind of looks like a chocolate chip cookie if you're thinking about it. We have different sized chips and they're going to be spread throughout it no matter how you look at it. So we have our kind of bile gas, peritoneum here, right? And then it's going to be hypoechoic to anything around it with like these chocolate chips inside of it. And then it is going to be either iso or hypo compared to the uterus. So if you have a side-by-side with your uterus and your ovary, they're going to be very isoechoic. So make sure you're looking for those borders, especially if that ovary is trying to hide behind your uterus. We talked a lot, not a lot, but a little bit about it changing size due to age. So that postmenopausal woman is going to have a very small ovary. Same thing with a premenarche. If they have not had their period, it's probably going to be very small. So we're going to keep our range within that age of menarche, that age of ovulation and fertility. And when we're measuring our ovary, so this is our longest axis. We may not be true sagittal or true transverse on this, but we're going to go to the longest axis of the ovary to measure it, and we're going to do a length and a height. Then we're going to go into the short axis. Again, we may be oblique. These things can move. They're not going to be straight up and down. They have a variable location. So the short axis is our transverse, and we're going to go directly right across into a transverse view of it. Between 2 and 5 centimeters, it's quite a range, guys, and then 1.5 to 3 centimeters by 0.6 to 2 centimeters. When you are asked a question about the ovary size, they are not going to ask you something like 3 by 3.1 by 3. They're going to be like 1.5. Like they're going to be very far off from these numbers. It's either going to be greater than 2 on this, or it's going to be less than 6 on this. So just kind of knowing like 0.5 to 2, half to 2 centimeters for the width, 1 to 3 for the height and for the width, and then 2 to 5 for the length. Knowing that range instead of exact 1.5 is going to do you better than not memorizing it because there's such a range. So remember, if they ask you on your boards, it is a range, but the numbers they give you are always going to be either lower than this by quite a bit or higher than this by quite a bit. So pick the one that is way off left field. And then, as I mentioned earlier, as we age, you don't use it, you lose it. That 5th decade of life, those ovaries kind of shrivel up and go bye-bye. Fallopian tubes. So I'm going to preface this by saying we do not normally see fallopian tubes on ultrasound. If we are seeing a fallopian tube on ultrasound, it's generally because there's some inflammation going on within that tube or some kind of pathology. They may just have large tubes, but it's just not something we routinely visualize. So they are, again, paired. We have a right and a left. They are just these huge muscles that main focus is to get that ovum from the ovary, once it's discharged, into the uterus. And then as it's going through, somewhere in there, and we're going to talk about this, it gets fertilized. So it comes in as an unfertilized egg, and then as it comes into the uterus, it is now fertilized. So it's composed of 3 layers. So we have our outer serosa, and then we have our middle muscle layer that's going to be responsible for moving that egg along through peristalsis, and then an internal mucosal layer that's going to be kind of like sticky but wet, so that that egg kind of goes all the way through without any issues. The 4 divisions of the fallopian tube are super important to know what is the division and what is its purpose. So I'm going to start here. Guys, this is my uterus right here in this image, the ultrasound image. And then this gray thing right here is my uterus. And here's my ovary. So again, here's my ovary right here. So we are looking at this tube coming from the uterus going down. I actually think this is my ovary here. I misjudged that. So uterus coming through the cornua of the uterus, coming around, and these are those fimbriae right here. Okay, so starting at the uterus, we have our interstitial. So the interstitial means inside the tissue. That's this part right here. It is going to be the thinnest, smallest portion that is dropping into the uterus. Then we have our isthmus. So we have our uterine tissue. This is outside of the uterine tissue. It is the short little part that comes right here outside of it. Then we have the ampulla. Now the ampulla is our biggest portion. And this is super important because when we have an ectopic pregnancy, this is where we're going to find it, in that very long ampulla. It is also where most fertilization happens. So sometimes when that egg is fertilized, it's like, oh, I'm fertilized, let me implant where I'm at. And that is not the way it's supposed to work. It's supposed to continue along that path, growing as it gets fertilized, but it stops there for some reason. And so we end up with an ampulla ectopic pregnancy. When we get to ectopic pregnancies, we'll talk about some other places, but just know that the ampulla is very common for fertilization and ectopic pregnancies. Then we have the infundibulum. This is just a funnel-shaped portion, so it's kind of wide. You can see it here widening out. And this is going to be the catcher's mitt of the ovum. It is ready to receive it. We have a wide area. That way, if it overshoots a little bit, it doesn't have a narrow tube to go into. It has a very nice spatial area to land. But the big thing here is that the infundibulum terminates into the fimbriae, and these fimbriae move. So if you have ever been in a pool and you're trying to get the water to move, you either bring your arms in and the water's moving in towards you, or you push it away and the water moves out. Well, that's what these fimbriae are doing. They're doing this, come hither movement towards the egg, so that the natural fluid we have in our abdomen pushes that egg into the infundibulum. So that is what it is doing. And it actually uses, once that egg comes in, so we have an egg here, it's very violently thrown out. These fimbriae are going to start moving, creating a wave. It's going to catch it, and as it catches it, it's going to start peristalsing, much like our bowel, to get up here. Once it gets in here, it's going to get fertilized by the sperm that have been looking for it for a very long time. It's going to start growing and maturing, going through some narrow passageway through the isthmus into the interstitial, and then boom, it is in the uterus and you are pregnant. But like I said, we don't routinely see that, so we do not have a slide on sonographic findings for the fallopian tubes. When we get to pathology, we'll talk about that a lot more. But I do want to stop and just appreciate for a moment all of the things that go into an ultrasound exam before we ever even get to utilize the anatomy that we've worked so hard to learn. And the big thing is knowing what the indications for a pelvic ultrasound are going to be. So we have two different types, right? We have a transabdominal, which looks over the abdominal wall, and then we have a transvaginal, which goes in through the vaginal canal, butting up against the cervix to see that uterus and ovaries nice and beautiful. Well, for a non-gravid patient, female patient, of course, we would need to have an indication that justifies us doing these exams. And those indications are pelvic pain, any sort of pelvic pain, any known uterine mass. So they may have had a CT that says, hey, they've got a mass on their right ovary. Can you please characterize it for us? Absolutely, we've got you. We are the gold standard for pelvic masses. That's why they come to us. If they're having abnormal uterine bleeding or dysfunction with their period, that's what dysmenorrhea means, meaning they're having heavy bleeding, irregular bleeding, no bleeding. That's what we're going to be looking for. Any feeling of bloating, discomfort in the vaginal or pelvic area, and then family history of gynecological carcinoma, so ovarian cancers, uterine cancers, breast cancers, those are all going to be kind of grouped into an exam that may be a yearly checkup for them. So when we're talking about our transducer and which transducer we're going to use, it really depends heavily on our patient's body habitus. So if I am doing a 14-year-old, 95-pound girl, I am not going to jump straight to a 2 megahertz curvilinear transducer. I don't have a lot of depth that needs penetration, so I'm going to opt for the highest frequency I can get, and generally that's going to fall within that like 5 megahertz transducer range. So I'm going to grab my curvilinear and we're going to take a look. Now the other flip side of that is, what if I have a 315-pound female? I'm probably going to opt for that 2 megahertz transducer. This is a very good exam question. They love asking you questions about which transducer would you use, given that your female patient who's in her 45s and weighs 290 pounds. and you're going to want to opt for the lower frequency for that. But any other time, you're going to say you're going to go with the highest possible frequency transducer that is fit for your patient's body habitus. Like, always go high, because then you get your resolution. Remember, the higher our frequency, the better the resolution. The lower our frequency, the better the depth penetration. So that's a trade-off from physics. Prep for transvaginal and transabdominal are very different. For transvaginal, we want an empty bladder. We do not want any urine in that bladder because we're going to be pushing right up against it. But for transabdominal, we need to have that bladder full in order to push the flexation of the uterus back enough so that we can see it. Also, the bladder creates a beautiful acoustic window for us and limits the amount of attenuation going that deep into the body. Patient positioning, we have supine. The other one that they love to throw in an exam is lithotomy. Basically, that just means laying back with your feet in the air. So stirrups for your transvaginal. So lithotomy. All right. Couple more slides.